We are now in the 10th meeting about renal nephropathology, but from a nephrology perspective. We are speaking now about the light microscopy of part of renal pathology. We finished already before with all the glomerular changes that may appear under the light microscope. And the last meeting, we discussed the slide in front of us. And I told this is a key to the pathological changes that may be encountered in the second part under light microscopy of nephropathology, that is of the tubules. And this key is simply considering abnormal changes in the basement membrane of the tubule, in the cells, whether in the form of injury or infiltration, as well as abnormalities in the lumen of the renal tubule. We discussed this before in the last meeting, and I will start with the first slide of our presentation today. There is another key to complement the first key pathological changes, which joins the pathological changes with the underlying disorder. So the disorder that making the previous changes, I termed this key to the renal tubular disorders, is caused by any of these diseases. For example, acute tubular injury, and as you know, acute tubular injury is a preferred newer term of acute tubular necrosis, and actually it includes also the acute tubular necrosis when there is loss of the nucleus from the renal tubular cell. The second disorder is the Tubulointerstitial nephritis. The third disorder is tubular atrophy, tubulitis, cast nephropathy, crystalline nephropathy, and viral inclusions in cases of renal allograft pathology. So if we complement the renal tubular disorders present in this slide, together with the previous key pathological changes, it will be easy for us to understand what is coming from the pathology slides. As we see, this is a picture of acute tubular necrosis. This is the older term because this is an older slide, as you see. But the finding here is there is sloughing of the tubular epithelium in this area, for example, of the tubule, and there is a cellular debris present inside the lumen. The same condition present in this tubule. Some of the renal tubular epithelial cells present here are already sloughed from its place and occluding the lumen. Similar in this situation, this is a proximal convoluted tubule. You see the brush border here, it is detached partly. And the type of cells present and the wider lumen, this is typical. This is also of the proximal tubular cells. So these are the finding of the acute tubular injury. This is the preferred term now. But in case there is absence of a nucleus from some of the cells and the cytoplasm of the tubule is in the form of eosinophilic granules, it is called acute tubular necrosis. Again, it is part of the whole spectrum of acute tubular injury. Again, this is another one of acute tubular injury with severe sloughing of the cells. You see this renal tubule as if it has no tubular epithelial cells at all. Okay, this is similar in all of these findings. It is to be noted that in this situation, if we look to the other items present in the pathology field, like the glomeruli, it will be normal. So the injury here is completely a tubular injury in the form of acute tubular injury, and it's a severe form of acute tubular necrosis. Again, as we see in this picture, many of the epithelial cells are detached and filling the lumen of the renal tubular cells. And again, this is another picture of acute tubular injury. and acute tubular necrosis. If you look carefully in some of these epithelial cells like here, you will find this is vacuolated. There are many vacuolation present inside these epithelial cells and here also. And this is a form of injury present in the tubular cells, one of the pathological changes again present in acute tubular injury. If we look to this slide, this is glomerulus in the middle of the field. It appears as if it is normal, no abnormality present in the glomerulus. But what is present in this picture? There is infiltration of the interstitium by several inflammatory cells present here, here. Together, some of these cells present in the interstitium are invading the epithelium of the renal tubule. So this is a case of tubulointerstitial nephritis. As we said before in our lectures, the type of the infiltrate present in this picture and in the similar picture of acute tubulointerstitial nephritis doesn't differentiate whether it is acute or chronic. Differentiating acute from chronic tubulointerstitial nephritis is mainly dependent upon the history. But if we are going to use pathological findings to discriminate acute from chronic, it is mainly considering the presence of edema in the acute and the presence of fibrosis in the chronic situation. But the type of infiltrate, for example, the presence of neutrophils or eosinophils or lymphocytes or monocytes, it doesn't differentiate. But the picture present in front of us, it includes tubulointerstitial nephritis. As we would like to say, for example, is there any fibrosis here? No, no much fibrosis, but the renal tubules are separated from each other by empty space like here. So we can say that this is a picture of acute tubulointerstitial nephritis with tubulitis. It is not uncommon to find, in addition to the presence of tubulointerstitial nephritis, some evidence of tubular injury. So both conditions may be present in the same patients because there is no very sharp demarcation in the pathological insult, depending upon the etiology, whether it is drug-induced or whatever etiology causing this tubulointerstitial nephritis. You may find additional to the tubulointerstitial nephritis evidence of some acute tubular injury. For example, if you look to these tubules, as I just told you, many vacuolation. These vacuolations present here among inside the renal tubular epithelial cells. This is not normal. This indicates injury of these renal tubular epithelial cells as part of the acute tubular injury. So we can say about this slide that there is evidence of acute tubulointerstitial nephritis together with acute tubular injury, but the glomerulus is pretty normal. Again, if you look to this picture, these are the renal tubules. There are interstitial inflammatory infiltrate present here in these areas. Okay, and some of this inflammatory infiltrate is already invading the nearby tubule and the renal tubular epithelial cells, as seen here. The presence of two or more of the inflammatory cells passing by the renal tubular epithelium is indicative of tubulitis, inflammation of the renal tubule by the presence of this inflammatory infiltrate. So it is called tubulointerstitial nephritis, inflammation in the interstitium as well as in the renal tubular epithelial cells. If we come back to the acute tubular injury, whether or not associated with acute tubular necrosis, can the pathology help to differentiate between the major two types we know about acute tubular injury, the toxic or the ischemic? Yes, but of course, we cannot depend completely on it for diagnosing whether the patient having ischemic or toxic acute tubular injury or necrosis. It is dependent mainly about the history of this patient and the circumstances that resulted in this acute tubular injury. But in simple words, the patient who have toxic or ischemic tubular necrosis can be differentiated, as we are going to see in the coming slide. But before going to the coming slide, there is important to notice that the severity of the morphological findings in patients with acute tubular injury often doesn't correlate well with the severity of the clinical manifestations. And we usually face this scenario when we see a patient who is presenting with acute tubular injury and renal biopsy was done because the etiology is not known, and we find the final pathology impression is the patient has evidence of acute tubular injury, but the changes are quite subtle. We face the patient serum creatinine may be 10, 11, 12, etc. And some of the attending colleague may be astonished how it comes that there are some subtle changes in the renal tubules, and despite this, the serum creatinine is very high. Maybe a mistake in the laboratory of serum creatinine? No. As this golden rule, this is very important. There is no correlation, or there is no good clinical correlation with the pathological correlation in cases of acute tubular injury. Coming back again to the question that I have just described. This is a diagram in order to show what is expected in patients who have ischemic as compared to the toxic acute tubular injury. The patient who is exposed to a certain toxic material from exogenous or endogenous sources, when it is filtered from the glomerulus, the first part will face this toxic material is the proximal convoluted tubule. So in cases of toxic form of acute tubular injury, as we see here, the main involvement, it is in the proximal convoluted tubule, and it is containing it in a complete form or in a diffuse form, as you see in this diagram. But in cases of ischemia, it is a patchy lesion according to the type of the ischemic insult. But in all the cases, there is patchy, not diffuse lesion as seen here, and it is not confined to the proximal convoluted tubule, may be present in the proximal, it may be present in the distal. So the pathologist may help, but of course, we are not waiting the report of the pathology in order to say this patient have ischemic or toxic. It is largely our nephrologist's job in order to know from the history and the exposure and the examination, vital data, etc., etc., etc. By this, we can say it is ischemic or toxic, but this is just an issue. If we Yes, I am with you. Sorry for the interruption, but this is a coffee effect. Oh. I'm just taking a very good cup of Turkish coffee, and this is expected if you take the coffee and make a lecture immediately after it. Okay. So if we look to this picture, for example, if I have a patient with acute tubular injury, and then I find the main injury is confined to the proximal convoluted tubule, and the proximal convoluted tubule is largely involved, we may suggest in a pathology term that this is toxic. But if we find the proximal, the distal, some of the collecting tubules are injured and the other parts of it are healthy or was healthy, this indicates that it is an ischemic lesion. Coming back to one of the other disorders we described in renal tubular disorders pathology, this is tubular atrophy. There are three forms of tubular atrophy in pathological terms. Okay, I will start with the third one, this here. It is called thyroidization of the renal tubule type of tubular atrophy. As you see here, the renal tubules are rounded, the epithelium is simplified, and there are uniform intratubular cusps mimicking the thyroid colloid. This is the thyroidization form of renal tubular atrophy. The second form is called the endocrinization form or endocrinized form of renal tubular atrophy. Here, the renal tubules are rather small. The lumen also is quite small. Sometimes the basement membrane is absent or maybe very thin. This is the endocrinization form of renal tubular atrophy. Okay, the third one, which is the most common form of renal tubular atrophy, is called the not otherwise specified or the classic form of renal tubular atrophy. That is why I started by these two terms. Before saying that this form is present, I have to exclude the other characteristic of thyroidization or endocrinization form of renal tubular atrophy. Here, this classic form of renal tubular atrophy is characterized by marked thickening of the renal tubular wall, okay, and its wrinkling appearance and lamellation as you see here. So, in cases of marked thickening and lamellation of the renal tubular basement membrane, it is a form of tubular atrophy. If it is very thin or even absent, again, it is another form of renal tubular atrophy. So these are the three types of renal tubular atrophy. The significance of renal tubular atrophy is that indicates the presence of chronic irreversible renal lesion as compared to the acute tubular injury. The patient who have acute tubular injury probably, and in the majority of cases, the renal tubules will regenerate and it is reversible. But the presence of tubular atrophy by whatever form of these three forms, it indicates chronic irreversible form of renal injury. This is magnification of the three previous picture. This is the classic non-otherwise specified form of renal tubular atrophy. I think now you will look in every picture about vacuolization. It is clear again here. This is a proximal convoluted tubule, by the way. There is marked vacuolization inside the cells, indicating the presence of injury or acute tubular injury in addition to this tubular atrophy, not astonishing to be present together. This is the endocrinization form of renal tubular atrophy. And this is the thyroidization form of renal tubular atrophy. As we discussed, the renal tubular atrophy and on the other hand, acute tubular injury together with the acute tubular necrosis, this table will help differentiate between the two conditions. This is an acute problem, reversible problem, but this is chronic, irreversible problem. Usually the size of renal tubules is large, but in here it is small. The basement membrane is of normal thickness or maybe thin, but here in the tubular atrophy, the renal tubular basement membrane may be thick, may be wrinkled, may be duplicated, and in the endocrinization form, it may be thin. The epithelial lining of the renal tubules may be flattened or detached and regenerating epithelium. But in cases of tubular atrophy, it is flattened and simplified and no evidence for regeneration. For example, there is no karyomegaly, there is no enlargement of the renal tubular cell nucleus or the presence of mitosis, like may be present in acute tubular necrosis when it is regenerating. The lumen is usually wide here with acute tubular injury, but it is usually narrow with the tubular atrophy. The content may contain debris or sometimes a granular cast together with acute tubular necrosis, but here with tubular atrophy, it may be nothing present inside the lumen, or it may be a thyroid-like colloid or cast present in the lumen in cases of the thyroidization form. The tubular to tubular relation to each other, usually the renal tubules are very adherent to each other, what is called back to back. But in cases of tubular atrophy, the renal tubules are separated from each other. I will again emphasize that sometimes you are going to find in the same pathology view or field, both conditions may be present at the same time. Acute tubular injury or acute tubular necrosis is more common to occur in the setting of chronic kidney disease. And with chronic kidney disease, from whatever etiology, we are going to find the tubular atrophy. This is the link that may join these conditions together, but this is in a very simple pathological terms, how to differentiate between these two types of tubular injury. One of the conditions, we rarely meet this condition, but sometimes it is like a puzzle. You are going to find a young boy or a young girl. It is more common among young boys in his, for example, 20 something like this, who is coming with renal failure of undetermined cause. The urine finding doesn't include significant proteinuria or hematuria or any active sediment. The ultrasound of the kidney, you may find that it is echogenic, or if we are lucky, we may find this picture of the ultrasound in which there are some few cysts present at the cortico-medullary junction, but don't rely about this picture because in the majority of cases, it is not present. And of course, if we cannot find a reason by making many investigation for this young boy presenting with renal failure, sometimes necessitating to start dialysis, and the boy together with his parents, all of these people together, of course, of us, we may be astonished, but what is the cause of this renal failure? All the historical data, all the laboratory features are not helping us to decide what is present. We proceed to take a renal biopsy. You may find this characteristic triad of a renal tubular disorder, which is previously called nephropathy. But the newer term that is used is autosomal tubulointerstitial kidney disease. Unfortunately, it is a reversible cause of renal failure, usually occurs in this young age group, okay, in the 20s, in the early 30s, maximum, the patient already become in end-stage renal disease without any evidence, except if there is positive family history in the dominant form of this disorder, but in many of these conditions, it is a recessive mode of inheritance, so even the family history is not helpful. Here, the pathology will help us by finding this characteristic triad that is affecting the renal tubules. Okay, the renal tubules are markedly dilated, as you see here from the biopsy of this patient, and the tubular basement membrane disruption. This is the second. And the third one is the presence of tubulointerstitial cell infiltrate with interstitial fibrosis and the periglomerular fibrosis, as you see here. This is the triad in pathology of this condition, previously called the nephropathy. By the way, nephropathy in Latin means vanishing of the glomeruli. because this disease with progression will result in fibrosis that will remove many of these renal tubules, and the glomeruli will be affected secondary to this disorder. And as I told you, it is characterized by the presence of multiple small cysts along the corticomedullary area, as we see here in the gross pathology. But again, don't rely in the diagnosis of this condition on finding these cysts, because in the majority of cases, sometimes even after doing a CT scan to the abdomen, you will not going to find these cysts. That is the rule, or the helpful rule of making a pathology. And of course, if we have a very fine pathologist like our pathologist in my country, you will help to diagnose this condition by the presence of this triad. Of course, this diagnosis is very important. As I told you, usually it affects young aged people. The opportunity of making renal transplantation for them is needed, but we need, of course, to know the underlying cause to avoid the presence of any disease that may recur in the renal allograft. So it will help here by doing a pathology and looking into the renal tubule to diagnose this rare condition. This is not common, this rare condition. As we discussed the last time, one of the issues in which we look inside the renal tubule lumen, you may find again another colloid-like cast or colloid-like debris inside the lumen in this issue. This is something different from the type of thyroidization form of tubular atrophy we just discussed now. But this condition you may meet in patients who have HIV. The presence of this slide, this is the glomerulus showing pseudo-crescent form or more marked proliferation of the visceral epithelial cells here in mauve color, collapsing the glomerular capillaries as you see here. This is a collapsing form of FSGS, and this is usually associated with marked dilatation of the renal tubule, making like a cyst. And inside the lumen, this colloid-like cast is present. The combination of these two conditions together highly suggestive of having HIV-associated nephropathy, which is called in abbreviation HIVAN, HIVAN. So this is one of the conditions that we may see inside the renal tubule. Together with this finding in the glomerulus will help to diagnose the condition. Sometimes we don't know from the start that the patient have HIV. And as you know, in some of the countries, it is not allowed to test HIV except after telling the patient, etc., etc. So if you find a lesion like this, we may help to diagnose even the underlying disease, the HIV-associated nephropathy. After we finish this, we are proceeding to speak on the other item of renal tubular affection, which is the cast nephropathy. There are many casts that may form inside the renal tubular lumen and will result in the condition called different cast nephropathy. It is not only speaking about the light chain cast nephropathy, which is usually linked to the term cast nephropathy of multiple myeloma or myeloma cast nephropathy, but of course it includes this and many other forms of casts. For example, we may find a hemoglobin cast resulting in occlusion of the renal tubular lumen and resulting in acute tubular injury. Okay, in several conditions associated with hemolysis. In patients who have a rhabdomyolysis or myoglobinuria, you may find a myoglobin cast, again occluding the lumen of the renal tubule. In the patient who have cholestasis, but with very high level of bilirubin, the serum bilirubin must be more than 16 milligram percent in order to cause this condition called bile cast nephropathy. Previously, it called cholemic nephropathy. But again, the newer term is this bile cast nephropathy. As we see here, it is written elevated total bilirubin must be over 20 milligram per deciliter. In some of the literature, it is stated more than 16. It is the same. Okay, so don't diagnose bile cast nephropathy in patients who have bilirubin, for example, 3, 4, 5, etc. It must be very high. Again, speaking about rhabdomyolysis associated acute kidney injury or myoglobin cast and acute kidney injury, usually this occurs when the CK is very high. Speaking about, for example, several thousands, not just 400 or 600. No, it must be several thousands. For example, more than 6,000, etc., in order to diagnose this myoglobin-associated acute kidney injury.
Professor Asami, I ask you just interpretation for
okay.
your very lovely table. I think one of the very important tables just for acute kidney injury hallmarks. But you may agree with me that it's a total diet bilirubin rather than, for example, hemolytic injury. Maybe the injury may be at lower limit than 20 milligram per deciliter. Just correct me if I am correct or not. So you are saying here in this table that total bilirubin above 20 milligram per deciliter. So if you have acute hemolysis and total bilirubin is not so huge, at what level we have to put here in the hemolysis associated kidney injury, and at what level of the direct bilirubin we can classify that not a total bilirubin? If you can have some clarification, yes.
Okay, of course, the bilirubin that is usually toxic to the kidney, it is mainly the direct bilirubin. Yes. So it is stated here that elevated total bilirubin more than 20 or more than 16, as I just said before. But in the majority of this total bilirubin, again, it is direct bilirubin that is the culprit. Okay, the indirect bilirubin is not that toxic as appears, and in the patient who have hemolysis, for example, and he developed acute kidney injury, if we are going to accuse a cast for causing this acute kidney injury, we may accuse the hemoglobin cast rather than accusing the bile cast in this situation. In the majority of cases of this bile cast nephropathy, it occurs in the presence of obstructive or what is called cholestasis. There must be element of obstructive affection bile duct in this situation. So despite it is not written clearly that it is direct or indirect, is written total, but in the majority of cases it is the direct bilirubin, and in most of these cases it occurs in the setting of cholestasis, not in any other forms of jaundice.
So if you allowed me just to say a statement for the our professors attending and other colleagues. So we classify that the diet bilirubin about 50% of the total bilirubin is considered that it is a cholestasis or obstructive jaundice. 50%. So yes. We have more than 20 milligram per deciliter, provided that on the total bilirubin, about 50% are direct bilirubin. Correct?
I think this is correct in my opinion.
If you allowed me as well, as we have from Khalid Abu Zaid, another note that hemosiderin in the urine, I think hemosiderin comes with the chronicity for hemosideриnuria, but in acute hemolysis, it's hemoglobinuria. There's a difference in the pathology. So hemoglobinuria can induce acute kidney injury, while hemosiderin, like in, for example, nocturnal hemoglobinuria, we can have hemosiderin precipitation in the renal tubular. So we can differentiate between hemoglobinuria and hemosiderin in renal chronicity of some sort of nocturnal hemoglobinuria. I'm correct?
I would like to emphasize something, Dr. Hisham. We have to differentiate between the urinary castus or the urinary finding and what I am speaking about now, about intratubular castus in pathology. Okay, these conditions are different, and it is not necessarily in the patient who have for example, myoglobin or hemoglobin cast, it is not necessarily to find in the urine similar finding to what is present in the pathology. These are two different issues. So don't mix between these conditions. My job now is to tell what is meant in pathological term about the different castes that may develop inside the lumen of the renal tubule, and in the majority of these cases, it is associated with AKI, and what is the clinical scenario in which these castes may develop, and how to differentiate. And I agree with you. I am interested actually about this table because it is very interesting and
yes, it's fantastic. Yes,
in very simple words, just telling the type, telling what is the clinical scenario you find this issue, what appears in the light microscopy, and the most important one is this. Okay, how to differentiate between the hemoglobin cast, myoglobin cast, bile cast, etc. It is in many cases dependent about the immunohistochemistry. For example, you cannot differentiate the hemoglobin from the myoglobin cast except after doing immunohistochemistry. Of course, we may use the clinical judgment of the patient. In cases of hemoglobin cast, we are speaking about a patient who is presenting with hemolytic crisis. But in the patient with myoglobin cast or rhabdomyolysis associated acute kidney injury, we are speaking about who has a traumatic injury to the muscles together with very high CK, etc., etc., etc. But I'm speaking just in pathological term. Is the looking of the cast in light microscopy will help to differentiate? If you look even to the description here about the light microscopy, nearly the same term is written here is written here. So cannot differentiate by just looking to the pathology. I may differentiate by the history, but if we like to certify what is going on in pathological term, there is no way except by doing immunohistochemistry in order to define whether it is a hemoglobin or a myoglobin cast or the other castes as we see. Also, another important remark here, please don't forget the name of this special stain. It is called Hall stain. This is a stain specific for staining the bile cast. Sometimes you cannot diagnose the bile cast nephropathy in pathology, except if we make staining by this stain. I am not sure if this is available in the routine.
It is not done routinely. We don't rely that we have clinical data for the hyperbilirubin and the acute kidney injury. And the clinical judgment between acute kidney injury or hepatorenal syndrome, for example, is the hallmark. But we didn't rely on the biopsy finding or in staining. I think we didn't almost did before a renal biopsy for patients with hyperbilirubin to judge what the condition of renal injury. You may agree on that or other colleagues. I don't remember that we did a biopsy for hyperbilirubinemia ever.
Yes, I agree. In the majority of cases, actually, in clinical practice, we didn't result to doing renal biopsy. We diagnose this in the majority of cases in clinical scenario. And actually, as we see, the patient will be in a complicated scenario that will not help to make a biopsy for him. But in case if it is done, this is the way how to diagnose and to use this special stain to help to diagnose the bile cast nephropathy if we would like to certify exactly what is behind this acute kidney injury. Again, in order to emphasize what is the importance of this immunohistochemistry, for example, the patient who have acute tubular necrosis, the castes here have no special staining, for example, but to exclude the myoglobin or hemoglobin cast from the outset before saying that it is this cast, the granular cast characteristic of acute tubular necrosis. So together with our colleague, I think you have to share me and Dr. Hisham the likely opinion about this good table in front of us. And I think together with Dr. Hisham, it will be a good examination question for our colleagues about the types of cast nephropathy in pathology. What is the clinical scenario? What is the light microscopy finding? And what is the special study or stains that may help definitely diagnose this condition? In the coming slides, we are going to look to some of these examples of cast nephropathy. But before looking to these different types of cast, I make this flow chart in order just to put it in your mind. Again, please concentrate with me. We are speaking about the renal tubular castes that we diagnose by pathology. I am not speaking about the urinary castes now. And there is no link between these two conditions. It is not necessary in the patient to have, for example, a bile cast nephropathy to find a bile cast or a similar bile cast in the urine. I'm speaking here in pathology terms about what are the different types of castes that may be encountered when making renal biopsy and making a pathology assessment for this patient. So I make this flow chart in this way, and I think we may agree later that it will help to put all the possibilities of castes that we may see in renal nephropathology without missing some of them. So it may be physiological castes or a pathological castes. Okay, the physiological castes, it may be a uromodulin, which is also called the tam horseful cast also, and the hyaline cast. These two conditions may look similar or may look as if we are speaking about the same term, but actually there are some differences between these conditions. Uromodulin cast means that the cast present in the lumen of the renal tubule is only formed of this tam horseful protein or uromodulin, which is a secretory product from the ascending limb of lobe of Henle and the beginning of the distal tubule. And the hyaline cast, it includes the uromodulin in addition to some other condensed protein together with this cast. Both conditions may be encountered in physiological situations without having any underlying renal disorder in this case. Okay, but pathological types of renal intertubular cast may be classified into exogenous and endogenous. By saying exogenous, I mean that this cast is caused by exogenous factor from outside the body. For example, exposure to certain drug, exposure to certain toxin from outside, and in fact, I specified the drug-induced cast nephropathy, and in particular in this exogenous form, I emphasize the vancomycin-associated tubular cast nephropathy. One of the lesions encountered in the kidney in people who are exposed to vancomycin, that it will result in the formation of special cast inside the lumen of the renal tubules, together with either tubulointerstitial nephritis or acute tubular injury, as we are going to see later. And actually, this cast formation inside the renal tubule caused by vancomycin, this is a new discovery. This is not known since a very long time. We know that vancomycin is potentially nephrotoxic, But the etiology or the underlying pathology of this condition and the formation of cast inside the tubule, actually this is to some what recently discovered. So this is what is called exogenous, for example, and the rest is allowable for many other drugs that will prove to cause similar scenario to vancomycin. And the endogenous pathological renal intratubular casts. The renal intratubular casts on other ways may be classified in those associated with acute tubular necrosis, or those associated with glomerulonephritis. In many of glomerulonephritis, we may find, in addition to glomerular disease, you may find cast inside the renal tubule. For example, the characteristic red blood cell casts, again inside the renal tubule. I am not speaking about the urinary cast. I'm speaking about the cast inside the renal tubule. And in systemic diseases present may result also in the formation of intratubular casts. So this is in broad terms speaking about the pathological renal intratubular casts. If we speak about the endogenous renal tubular casts that may result in acute tubular injury or acute tubular necrosis, as I told you, it may be hemoglobin cast, the red blood cell cast, the neutrophilic casts, as in cases of acute pyelonephritis, in addition to presence of interstitial inflammation and tubulitis. You may find a neutrophil cast inside the lumen of the renal tubule, the bile cast, the presence of granular casts in cases of acute tubular necrosis, hemoglobin cast, and the light cast characteristic of myeloma cast nephropathy. This is the hemoglobin cast. If you look to it in the light microscope, this appears like a cast full of many granules inside this cast, as you see in this clinical scenario. So by light microscopy till now, whether in the hematoxin and the eosine or whether in the VS stain, all of us can say there is a cast inside the lumen of the renal tubule. And probably it will help in the etiology of causing acute tubular injury or acute tubular necrosis. As we see here, some of the renal tubular epithelial cells are shedded from its basement membrane. Also here, there is vacuolization. So this is a scenario of acute tubular injury necrosis together with the formation of renal tubular cast. And the same condition, but under different stain with BAS, the cast is formed or characteristically formed of many small granules forming this cast. But till now, this light microscopic appearance cannot tell it is a hemoglobin cast or myoglobin cast or bile cast or whatever cast. The discrimination between these, as we see in the former table, it includes the immunohistochemistry and, of course, before this pathology, finding the clinical scenario and the laboratory finding in these patients. This is after making immunohistochemistry in this patient with granular cast, the immunohistochemistry against hemoglobin A. It will give a positive staining, as we see here. So in this immunohistochemistry finding, this is the documentation in pathological term, that is, it is a hemoglobin cast. The picture in front of us include several forms of renal tubular red blood cell casts. This is very beautiful red blood cell cast, studied of many non-nucleated cells. This is the characteristic of red blood cells. It is not nucleated, and it is the cast is studied with many of these red blood cells present inside the lumen. This is example of red blood cell cast. These are other examples of red blood cell casts and hemoglobin casts. Together, both of these conditions may be present in the same patient in some scenario. For example, this relatively new entity, we heard about it, and every now and then we see a patient who having anticoagulant-related nephropathy. Anticoagulant-related nephropathy, if he perform a biopsy for this patient, of course, after the INR returned back to normal after stopping warfarin, which is the usual culprit causing this condition, despite it may be caused also by other oral anticoagulant, but it is formally called warfarin-associated nephropathy. You may find this scenario: red blood cell casts, blood present or hemoglobin cast or blood present inside the renal tubules in this way, and you cannot find any other pathological changes present in the glomeruli, etc. For example, in this patient, this case scenario of a patient who is 41 years old, Caucasian female, with aortic bifurcation thrombosis, post-bypass graft placement. The patient was on warfarin therapy. Imagine how much the INR for this patient. It is 27. Okay, the baseline serum creatinine of this lady was 1 and it jumped to 6.7. The patient complained from gross hematuria, and in the urine they find red blood cell casts in the urine. The complement levels were normal, ANA and test were negative, immunofluorescence was negative, the glomerular basement membrane was normal, everything was normal until we come here and we find inside the renal tubule the presence of these red blood cells or red blood cell cast present inside the lumen. This together with the clinical scenario and the exclusion of other causes that may result in this acute kidney injury clinched the diagnosis of warfarin-associated acute kidney injury, which is now called, in order to broaden the spectrum to include other oral anticoagulant-related nephropathy, ARN. Again, this is another renal biopsy of patient that presented with this relatively new entity. In order to diagnose it, the patient must be using warfarin in the majority of cases, and the INR should be above 3. And may have evidence of bleeding from other areas in the body, and presenting with acute kidney injury. We rolled out the other possibilities for causing this acute kidney injury, and ultimately renal biopsy done again after the INR settled down to normal, because of course we cannot make a renal biopsy in patients with high INR by this figure 3 or 27 like the other patient, and then make renal biopsy. This is a documented diagnosis. You will find this bleeding inside. Actually, it is bleeding inside the kidney. Red blood cells are present everywhere, including red blood cells inside the tubular lumen and the red blood cell casts. This clinches the diagnosis of anticoagulation-related nephropathy.
I can interpret it just for a second, just to, if you allow me, Professor Hassan.
Yes.
If you go back one slide, you can find the, as you perfectly described, that the entity. We are still talking about hemoglobinuria and the precipitation in the renal tubule. The cast takes the shape of the tubule, or the cast may have a significant shape inside the tubule. For example, myoglobin is a globular structure, and its molecular weight could be removed easily by the renal dialysis system because its molecular weight is 17,000, but hardly removed actually because it's a globular. In case to remove through the pores is difficult. While the hemoglobin, free hemoglobin, its molecular weight is above 60,000, and it's like a chain, not a globular in structure, but by the cutoff of the dialysis membrane can be removed. So my question that may be here, I understand that the cast will take the shape of a tube. But do you can differentiate by the shape of the molecule itself? Is it globular or chain-like in the biopsy?
You ask if we can diagnose, for example, myoglobin cast nephropathy, if we find it globular in shape?
Yes,
This is your question?
Yes, my question is related to the clinical sequelae of a patient with hemoglobinuria or myoglobinuria, the difference in the removal of dialysis, the renal replacement therapy. You know that we are not treating as well just uremia, we are treating as well to remove the proposing toxins here in the hemoglobin. We are cannot remove hemoglobin because its molecular weight is high. Myoglobin, its production is high, but unfortunately, it is one of the structural changes against the pores for squeezing. And if you compare that, you can remove light chain, kappa and lambda light chain, because it could be removed through the pores, while myoglobin, by its nature, structure is smaller, but still globular. So the removal through extra-renal therapy, extracorporeal, is difficult. So my question, how we can decide that inside the tubule, the globular or the chain-like structure?
I think, in my opinion, Dr. Hisham, that these are two different stories. The story of removal of the casts by dialysis, whether you are speaking about myeloma or myoglobin cast, this is another issue considering molecular weight, something like this, and the membrane we are using for removal of this condition. But I think this is not to be correlated with the shape of the cast inside the renal tubule, whether it is globular or whether it has a different appearance. I think these two conditions, I cannot group them together actually in a single scenario. Maybe I am defective in not reaching this joining between these two scenarios, but I think the story is different. We are speaking about removal of molecules by dialysis. It needs physics in this situation, but we are speaking now about a pathology finding. And as you see, if we look to the section in pathology in a certain way, we may find it globular. If we look in another way, you might find it, for example, oval. If you look to another,
it depends on the tubule cutting. Yes, it depends on the cutting of the specimen and the tubular structure and tubular shape.
Yes.
Okay, thank you very much. We can continue, please.
So when we are speaking about this anticoagulation-related nephropathy, actually, I passed by the most recent issue of the Journal of the American Society of Nephrology this month in November. Okay, there is an article about the updated management of anticoagulation-related nephropathy, just in order to complement the pathology by some clinical data. And actually, because this is something very recent, as you see, I just picked up this figure from this article, and I invite all of my colleagues to read this article. This is only 8 pages or maybe less, and it includes the updated data about this scenario. Actually, we see this condition not rare. Okay, so how to diagnose anticoagulation-related nephropathy now? Patient who is starting anticoagulation therapy, and later on the patient developed the AKI in terms of increase of absolute serum creatinine by 0.3 milligram per deciliter above the baseline, or more than 50% above the baseline, either of this condition. So here we diagnose the acute kidney injury. At first, we have to roll out any possible etiology to explain this acute kidney injury by the usual workup. urine analysis, urine electrolyte, abdominal ultrasound, any other immunological marker you wanted to make for this patient. And after making all of this, if an etiology to explain this acute kidney injury was found, well and good. But if you didn't find any etiology to explain this acute kidney injury in the patient who is using oral anticoagulation, and now the issue of having anticoagulant-related nephropathy, it is to be considered, okay? It is written here, if there is no obvious etiology, if the patient has hematuria in urine analysis or no hematuria, the diagnosis of acute anticoagulant-related nephropathy, it may be modest suspicion in the presence of no hematuria, because some of our colleagues may consider that it is a necessity to find hematuria in the clinical scenario of this condition. No, it is not a necessity. Okay, it may.
Dr. Said has a comment here.
It may. Okay, just please 1 second. I will finish this, then I will comment of Dr. Said. Okay, but even in the absence of hematuria, still there is a modest suspicion of anticoagulation-related nephropathy. But of course, if the patient have already hematuria, and I think this flow chart needs to put in a clear way that the INR must be more than 3 if the patient is using warfarin, of course. Because if the patient is not using warfarin, INR will not work with us here. For example, if he's using dabigatran or the other oral
we cannot check for INR, yes.
Okay, so I think this is the issue why they didn't mention clearly here INR, because they are not speaking about warfarin only, they are speaking about an anticoagulation. So this simple algorithm in a recent article, in order to make a good show, I brought it in order to complement the issue of red blood cell casts in the renal tubule. You are much welcome, Dr. Said.
Please share with us this important paper if you have on my email, so I can share with the colleagues on the WhatsApp group.
Yeah, I have the full article, Professor Assam. I can send it.
Yes, please. Yes, please. Yes.
After we finish this talking. No, I would like to appreciate what Professor Assam mentioned regarding this crucial issue, actually, regarding ARN. And basically, as he said, that it is a diagnosis by exclusion. But in the meantime, some at that moment will be very challenging.
Please repeat, Professor Said, because voice had been declined.
Just I would like to appreciate what Professor Assam mentioned actually regarding the ARN or anticoagulation-related nephropathy. And I know that it is a very challenging issue, especially if you wanted to do this renal biopsy in the dilemma of high INR and so on. So I think basically, as Professor Assam mentioned, basically we depend on the clinical scenario more than the biopsy. And if you do biopsy, just to rule out or rule in the other causes of acute kidney injury. So it is very challenging, really, issue, and we should stop for a while, if applicable. I mean, the anticoagulant to rule out, to avoid more and more progression of this disease, at least for a while, till we see what's going on. Thank you, Professor Assam.
Much thank you, Dr. Said.
So this is the last slide, or you are going because we... what do you think, Professor Assam? This is your last slide, or you have one or more slides?
You are the boss. At any time, tell me we have to stop at this time. And
I wish. You are the star of the nephropathology. So I'm just a moderator. I'm learning from all of you. So we can stop here for a while, because we all are still waiting for the excitement of the cases discussion by Professor Amr Hussain and his very elegant team, and we have 2 additional teams. So I will stop here for the 10th nephropathology. Great, amazing, and awesome session as usual. And we can move, and please keep your seats warm, Professor Sam and other colleagues, because what is going on will be more exciting. Thank you very much, Professor Sam.
Thank you, Dr. Hisham. Thank you for all our colleagues, and much welcome the Professor Amr and his colleague.
Thank you.
Thank you so much.